It is just a huge honor for me today to be podcast interviewing Dr. Gerald Stanley Samson, DDS, ABO, FACD, TE, is described as an educational entertainer. Gerry completed Pediatric Dental Residency at Emory University in '79 and Orthodontic Residency at Northwestern University in '81. So he's a double specialty, which would be medicine. Dentistry is a subspecialty of medicine, and ortho and pediatric are a subspecialty of medicine. It's medicine, dentistry is a specialty, and then pediatric orthodontist subspecialty. My gosh, for 39 years, from '81 to 2016, Gerry had an exclusive orthodontic practice in Atlanta, Georgia. He is a diplomat of the American Board of Orthodontics and fellow of the American College of Dentists. Currently, he holds formal faculty appointments at 6 university postgraduate programs in the States, lectures extensively, reviews articles submitted for publication to the American Journal of Orthodontics and the Angle Orthodontist. In addition, Gerry is orthodontic clinical director for specialty dental brands, consultant for White Oak Orthodontic Products, GC Orthodontic Lab, Pediatric Dental Anesthesia Associates, and Reliance Orthodontics. My God, it is beyond an honor. I hope you're watching this on iTunes, because if you're seeing Gerry and me on YouTube, he's got some wickedly good hair. How are you doing, Gerald?
I'm fine. Thanks for asking. I'm listening to all of that thinking, who is that guy? Who's he talking? Yeah, my parents would be so proud. Well, just before I think Howard hit the record button, we were talking about specialties in medicine and specialties in dentistry. And I said to Howard, well, Howard, what do you think the most challenging and difficult specialty is in dentistry? What do you think it is, Howard?
Well, I'd say pediatric dentistry, because I'd turn in my license and go work at Taco Bell before I took that gig. I just couldn't think of anything worse than being a pediatric dentist.
And you mean that in the kindest possible way.
And I have 4 boys, and they made Grandpa 6 grandchildren. I love kids. I just don't want to give them a shot and do a pulpotomy. And oh my God, my heart's beating, and I just want it to be over.
Well, I think the most difficult of all dentistry is general dentistry, the specialty of general dentistry. And I think that any so-called specialist that would be shaken to being awake in the middle of the night would say, you're right. That's why I'm not doing it. It's too difficult. So I have immense respect for general dentists, because it was too difficult for me to do. I couldn't keep doing all those change-ups. And it became obvious that pediatric dentistry was much more to my liking. And well, for example, I mean, let's look at restorations. I mean, how long does a restoration have to last for a pediatric dentist? Until the primary tooth falls out. Perfect.
Well, that'd be a good thing to talk about, because I'll never forget a kid in my class, and when I went to UMKC Dental School, he's Barry Polensky, and he told me one day, he said that he was going to be an endodontist. And I said, really? You love endo so much you just want to do root canals? And he goes, Howard, I don't want to learn. I can't learn all these oral surgery, endo, perio, pediatric dentistry, ortho, pros, dental anesthesia, oral facial pain, oral medicine, oral path, oral radiology, dental public health. He goes, I just want to narrow this down to just one area and do that. He goes, that seems to be so much greater. And so you got 2, you're an orthodontist, a pediatric dentist, and a dentist. I mean, and these kids come out of school and they want to learn everything. They say, well, I want to learn how to place implants. It's like, dude, just bone grafting alone should be a specialty. And then they want to do endo, then perio and pediatric dentistry, and learn about silver diamine fluoride. And then they want to do Invisalign. And I mean, my gosh, I love their enthusiasm, but man, it's so competitive that the first thing you got to do is you got to get out of school and get good at one thing. You got to get good at something. And I think Barry Polensky is right. Become a specialist. But, 1900, there were no specialties. 2000, there were 8. Now it's just 2021, and we're up to 12. I mean, it's definitely going to specialize, just like Adam Smith said in Wealth of Nations. I mean, specialization made the assembly line, increased our productivity. It's just the way to go. But what do you say to a kid who wants to learn everything and do everything?
Well, I'd say to anyone listening that every successful business, every successful person has something in common, and that is they have a niche or a niche. You have yours, Howard. And if someone who becomes too diverse, I think it's the old saying of becoming a master of everything is quite difficult, and therefore you become a master of nothing. So, for example, in pediatric dentistry, I was a good general dentist. I was good. But all of us in our classes have people that were really good, gifted in general dentistry, and I wasn't one of them. And I thought being good is okay, but I have to find something where I'm really good. And it was pediatric dentistry, mostly, I think, because of the compassion for the patients that I didn't really feel that way about adults. I thought, adult patients, let the buyer beware. But a kid, the kid doesn't even want to be there. It's the parent's decision to bring the child in. And my niche in that area, I was, at least my instructors told me that they were quite delighted with my ability to diagnose, treat, and restore. But where I felt that I heard the voice of the siren was in behavior management, not just of the child, but of the parent. Because any pediatric dentist knows you're not just managing that kid, you're managing the whole family for the good of the kid and the good of the specialty. But next thing that happened with me is I became quite fascinated with growth and development. And growth and development is something, it's sort of like Sam Clements, better known as Mark Twain, once said, everybody talks about the weather, but no one does anything about it. Mm-hmm. Well, in growth and development, what was happening in 1979, when I was finishing my second year at Emory in pediatric dentistry, is McNamara had been introduced to Rolf Frankel by Tom Graber, and everything in orthodontics flipped upside down. That all of a sudden that you could grow mandibles and grow maxillas and change vertical facial patterns to horizontal facial patterns. It was interesting, Howard, that everybody said that, but nobody had any proof for it except this evidence, or so-called clinical evidence, from Rolf Frankel, and everything flipped. And what happened eventually is, once people really looked at this with a scientific eye and listened with a scientific ear, it turned out you couldn't grow mandibles. You could only do dental alveolar change. So that's why I went into orthodontics. It was because of this fascination with the potential to avoid orthognathic surgery. That in the short version, that's what I did. Now, before we rave on, I think what's interesting for people to hear, and I'll base this on my bias of what I like to hear, which is I'd like to know who I'm listening to. And if you're a researcher, well, then you should be listening to someone who does research. If you're a teacher, you should be listening to someone who teaches in addition to their other things. And I was in private practice, as you mentioned earlier, for 38 years, but I had this will come as a shock to you, Howard. I had a very odd practice for an American orthodontist. First of all, it was limited to only children and teenagers. I did not want to treat adult orthodontic patients with their perio and their endo and their psychology and their oral hygiene and their attitude and their agenda. I don't want to hear it. With the kids, I'm ready. I like the tough kids. I like the easy compliance kids. I like the defiant kids. I like the children who are afraid. I liked all of them. Children and adolescents. Now, some of the parents need to be held under the water for a few minutes, but I got very good at faking it on that one. So my niche there was children and teenagers. Now, the next thing is, and again, people may want to ask for some oxygen after they hear this one, is I practiced in one office with one assistant and one front desk person and did not accept insurance for the vast majority of my career. I didn't actually change the insurance part until I sold the practice. And then the new owner wanted to accept insurance, and that was their business decision, not mine. So imagine that, Howard. An orthodontist in the United States with one assistant, one front desk, doesn't accept insurance. So essentially what I did was I did all my own treatment, and I never said I did better orthodontic treatment than anybody, because anybody listening to this knows that just about the time you think you have dentistry figured out, you're going to get hit. And no, you don't have it figured out. So for people listening, that is the way I practiced orthodontics. And then I was a very unlikely match to become involved in the dental service organization sector, or DSO, which is again, it's kind of an odd thing that I would have become involved with. That, as you mentioned, being clinic director for specialty dental brands, as well as advising QC is the correct name of the lab, QC Ortho Lab, and Reliance Orthodontics, and these university appointments. So in a not so brief thumbnail sketch, that's kind of where I'm coming from.
So, my gosh, I got so many questions for you that you already talked to. My gosh, I don't even know how far back to go. I first want to go back to the Neanderthal thing. The New York Times ran this big article. You said you loved orthodontics, you loved the research, you loved the science of it, and all your theories can flip on a dime if you have the right evidence and observations. But there's these. New York Times ran an article how two British orthodontists became celebrities to incels. The Muse, a father and son team of orthodontists, have an unusual theory about the source of crooked teeth, one that has earned them a following in some of the darker corners of the internet. Yay or nay? Are you the fans of the Muse? Do you believe anything their observations or theories?
Well, I've read enough about them to question most everything they say, because they appeal to emotions, and they appeal to basically their audience. Their approach to things is to tell everybody else they're doing things wrong, and that they're the only ones doing things right. And they ignore any, what I would call, clinical decisions based on science. So, and I think that there's people who are very attracted to that. In some circles, they might be considered quacks, actually. So, and I probably would be in that circle. I don't really see that the Muse have anything of substance. And I'm sure that your listeners that are fans of the Muse, let's see, what is it, John Mew and his son, Minnie Mew, that they'll probably take exception to what I'm saying. But one needs to recall that the burden of proof are on the people that make the claims. The burden of proof is not on me to prove someone wrong. It's on them to show good evidence that they're doing things right. So before you hit your next question, let me address this. Why is evidence, good evidence, published in refereed journals? Why is it important to make clinical decisions based on science? Why is that even important at all? Especially in orthodontics, because in pediatric dentistry, there tends to be a consensus about many things in clinical pediatric dentistry. But in orthodontics, there extraction, non-extraction, Howard. How long has that argument been going on? Extraction, non-extraction, that argument has been going on since the time of Edward Hartley Angle. So it's on for 100 years. What is the right orthodontic appliance to use of all of these pre-adjusted or straight wire prescriptions? Why aren't we all doing it? Why don't we how about the right retainer? Do you know that according to the Cochrane collaboration, which would be the evidence-based people, there is no agreement about what the right retainer is or how it should be worn or used. There is no agreement. What's the right cephalometric analysis, and why don't we all use it? What's the right arch wire sequence? What's the right time to start a class 2? There is no agreement. So especially in orthodontics, well, my take on this, and this is purely my opinion, is I would ask anyone listening and or watching this that does practice some sort of craft or art or science. What do you do when things don't work out? When things haven't worked out and you find that you're being chased by your own shadow, because the price that you pay, if you actually care about what it is you are doing, let's call it the patients, it hurts when things don't work out. It's painful emotionally, it hurts. Well, how do you solve that problem? And for me, the answer is I'm doing the best I can, which means as much as I possibly can, I'm making my clinical decisions based on science. So as far as your question about this malocclusion thing in the New York Times article, I think it's a lopsided view.
Well, I always thought to myself, imagine you were a Neanderthal living 10,000 years ago. What could you really do that would have changed the course of Neanderthals? Nothing. I mean, the pyramids were built 5,000 years ago. Pythagoras started their geometry cult 2,500 years ago, and here we are, 2000 AD. I figure it's probably going to be another 5,000 years before sapien just really understands what the hell's going on in the universe. So I think that's why they always say dentistry is an art and a science. We got a lot of science, and a lot of people are not science driven. I think at least a quarter of all people. It's the same in dentists. I mean, I can't believe with dentists. I mean, I've asked them a million times on Dental Town and in lectures. Okay, a silver filling is made of metal, and half of it's mercury, which you'll never find in the multivitamins. The other half is silver diamine fluoride, tin, stannous mouthwash. I mean, it's all antibacterial, and the fillings fail from biological infection, and which lasts longer, that metal toxic contraption or this inert little plastic filling that's just all inert. And from the research, a posterior composite lasts about 6 or 7 years, and these metal ones last 18 to 25 years from a million different studies. And the dentists say, well, not in my hands. In my hands, I'm special, and I'm so special. My little white plastic. Heck, if you found a homeless person behind a dumpster and you walked up to him and said, here's the white plastic fork from Kentucky Fried Chicken, and here's the metal fork from my mom's kitchen drawer, which one lasts longer? And the dentist would pick the white plastic fork. So humans always want to believe what they want to believe, and they hate an inconvenient fact that throws their whole logic upside down.
That's exactly correct. That facts do not change behavior. Emotions change behavior. And for example, some of the things we just talked about with the muse, that couldn't be more true. This comes from a book called Stumbling on Happiness by Dan Gilbert, a brilliant researcher, psychologist, about what makes people happy. Well, my takeaway from reading that book, Stumbling on Happiness by Dan Gilbert, phenomenal. It's all the research behind what makes people happy and what doesn't. And my takeaway is real straightforward, Howard. You know what makes people happy, Howard?
Booze and women. Did I get it right?
Well, I can see that. I can see where the clapper strikes the bell on this show. Being right. People want to be right. So if anybody, if you said to me, Howard, if you said now in your dentistry, Gerry, you need to change that. What's the first thing that would come to the human mind is, what's wrong with it? Well, you didn't say there was anything wrong with it. You said change, and change to most people connotates something is wrong. That is not accurate. And that's the first thing people need to get over. And, for example, Howard, let's take a look at this. What's the definition of evidence-based medicine or evidence-based dentistry from the Cochrane Group? Now, I won't stress you on this one because most people that I speak with, they can't quote the definition of evidence-based. Well, it is treatment based upon the best evidence available at the time the treatment was rendered or given. Treatment based on the best evidence available at the time the treatment was given for that individual, Howard. So how about that? It includes for that individual. That means, what did the person want done? And in this country, we are obligated by law, it says someone who I think you know quite historically is Larry Gerald. Larry is quite a good friend of mine. Aren't you familiar with him, Howard?
Larry Gerald?
Yeah, he's somebody you really should get on the show. Larry is a general dentist, of course, but he's also an orthodontist, and he has a law degree and a degree in ethics and the humanities from Columbia. He is extremely interesting. And Larry's comment about whatever medical or dental treatment we offer, we are never allowed to dictate an end result for the patient. This is what you have to do. We are not allowed to lead anybody to believe that. What we are only allowed to do is tell people their choices and tell them this is what's most likely will happen if you do, and this is what's most likely will happen if you don't. You offer them choices. So, and then of course people get their emotions mixed into this because, as I just said, people want to be right. And a tremendous amount of confusion happens on the part of the patient getting second opinions. Treatment based upon the best evidence available at the time the treatment was rendered for that individual. That means when better information comes to light, that if we expect to be taken seriously as a learned calling in dentistry, we should change what we are doing when better evidence becomes available, you see?
Yes, that is a I tried to find that definition. I found evidence-based medicine was originally defined as a conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individuals. The practice of evidence-based medicine means integrating individual clinical expertise with the best available external clinical evidence from systemic research. I liked your more succinct definition. Do you have that somewhere?
Yeah, I do. I seem to recall it's a paraphrasing from the Cochrane Group.
Okay. Okay. I'll Google that. Evidence-based medicine.
But this term, to give credit where it's due, which I'm quite enthusiastic about, the practicing evidence-based dentistry. Well, what does that supposed to mean? Does that mean that there's a consensus, that there's an agreement? Well, as I just mentioned in orthodontics, that really is tough to find. There's more argument than not. There's more argument than agreement. There's only agreement in these little clubs and cliques that develop. But my colleague and highly respected friend, Martha Ann Keels, who's a pediatric dentist with a PhD in epidemiology, she's the one that pointed out to me what we are actually doing is making clinical decisions based on science. So you take all of your clinical stuff that you mentioned and whatever science does or does not mean to the person, and that's how you make your final decision. Now, this is kind of a large issue. What if the patient, regardless of the type of dentistry or medicine, what if the patient doesn't really seem to be on board with this? What's the best possible thing the doctor could do? And the entire team, because the team is going to be asked, right? They're going to ask the front desk, well, what do you think? Or the hygienist, what do you think? Or the assistant, what do you think? After the doctor told them, now that it's very likely they'll ask someone else. So what's the best possible answer as far as I'm concerned, if someone isn't giving you, the doctor, a lot of, yeah, I understand, let's do that. This is the option I want. The best possible thing one could do is tell them to get another opinion and put that in the record. That is really critical. Now, that's coming from Larry Gerald as well as from me. That if you document that you told the patient, you know what, I want you to feel comfortable making a final decision. So why don't you get some other opinions? And then if I can help, let me hear from you. And document that you told them that.
What was the name of your orthodontist lawyer friend?
Larry Gerald, Jerrold. So if there's one takeaway from this rant and rattle, is everyone should hear that when in doubt, encourage the patient and document that they should get some other opinions. Now, if the whip comes down, either from a state board or even worse, from an attorney, and you have documented that you told them to get some other opinions, and they did or did not do that and came back to you anyway, and now they decide they don't like you, well, that's going to be very, very influential in someone making a judgment call about if the doctor behaved appropriately. You are never, ever sorry you encouraged second opinions. You could be really sorry that you didn't.
Well, let's go. I loved your example about 4 bicuspid extraction. You had a lot of people who just decided they were against it. And probably like all laws, they were written to right or wrong. So obviously they saw cases where there shouldn't have been extraction. I would say all that in my own life. I know when I was a child, our family dentist, all ortho was 4 bicuspid extraction. So it was done too much. So instead of finding the science and where this pendulum swings back to the right way, the same people swing it all the way to the other way. And whenever you're an extremist, I mean, if you're a dentist and you say that for all 8 billion sapiens on planet Earth, no one is a candidate for 4 bicuspid extraction, well then you're a crazy man. You're a crazy man who happens to be a dentist. You're certainly not a scientist. I mean, it is and the human mind is wild. Like they can believe the craziest things in other subjects, but be really good in dentistry. I have some friends who are so scientifically smart in dentistry, but then when you go to some other categories like religion, politics, and other things like that, they're just completely disconnected from reality and live in a fantasy bubble.
I think we have the same friends.
Yeah.
I mean, I had a close friend, sadly passed away, but he was so bright. He happened to be an oral and maxillofacial surgeon. He knew so much about so many things. It was incredible. But if you ever asked him the question, do you think there's life on other planets? He'd say, absolutely not. Because God meant it to be that we would be the only life. We would be the only human life. I thought, wow, okay. I think it's time to talk about exodontia. Yeah, anybody who's an extremist, that just doesn't make sense. I mean,
like I'm going to turn 59 this year. My oldest sister is a 61. She's been a nun before I was a dentist. She went straight out of high school, straight into the nunnery. I could spend 40 days and 40 nights with her and not be able to change one thought she has. I mean, so some minds are just not like that. And I want to ask regarding orthodontists, back to that 4 bicuspid extraction. A lot of orthodontists get upset. They're saying, well, how do you handle a referral who won't let you do 4 bicuspid extraction? And I always say, well, how do you handle one of your colleagues that says they use 100% clear aligners and there's not one case that they would need fixed appliances? Is that reality, or is that the same?
Well, you just had somebody on your show that's doing that. A very close and respected colleague of mine, Stefan Reinhardt, in Montreal, Quebec, a general dentist who is very, very bright, very bright. I don't care what as a matter of fact, is dogmatic as many of my orthodontic colleagues can be, that no, only an orthodontist should do or teach. Well, I will tell you this. Are you aware that Stefan was invited by Martin Palomo, who's the director of the orthodontic program at Case Western Reserve University in Cleveland? He was invited to speak to the postgraduate students about clear aligners. Now, that's major stuff. I mean, Case Western, that is really a big deal. So it's like one time Lyle Johnston. Check this out, Howard. Lyle Johnston, who I'm in the realm of people that think he's the most brilliant clinical researcher in orthodontics who's ever lived, for real.
What's his name? What's his name?
Lyle E. Johnston, not Johnson, Johnston. He has a PhD in neuroanatomy, a master's in orthodontics, and his postgraduate students, I'm quite sure this is correct, won more major research awards than anybody in orthodontic history. Lyle E. Johnson and Jay Bowman, a superb orthodontist in Kalamazoo, Michigan, is one of his students. Well, Lyle's comment about many of these things is well worth taking. One of his comments is, when everything works, nothing matters. It only matters when something isn't working. And then people start running in circles. So this idea about extraction, non-extraction, you were spot on with that, Howard, because during the days of Edward Hartley Angle said, make the occlusion class 1. This is 1907. Make the occlusion class 1 and the bone will grow. The bone will magically grow. It's called the functional concept of occlusion and orthodontics. Bone growth based on function. And Howard, the man went to his grave believing he was right. Even when better information came to light from his own disciples, one of which was Charlie Tweed, that sometimes you have to remove teeth, that there's just a mismatch between the arch size, the arch shape, and the tooth mass. I mean, if you have average arches and big crowns, you're going to have crowding. If you have average arches and small crowns, you're going to have spacing. You may have rotations, but there's going to be spacing, general spacing. If you have average arches and average teeth, well, then you're not likely to have much in the way of crowding. But the idea that every case can be treated without exception, and I've run into this many times in my career as an educator, the idea that you can treat everything non-extraction is absolutely absurd. It's absurd. And if that's true, then why aren't they showing proof of that? Where are their bragging rights? Now, back just for a second to this clear aligner thing. Is it possible that you could treat everything with clear aligners and no fixed appliances? Well, if it weren't for, if you listen to the marketing of the companies that are marketeers, and they're experts at swinging your emotions. And that is allowable in the United States. In the United Kingdom, you can't make these claims without evidence. They put the quietus on you. In this country, all right, we have free speech, and until someone brings a legal action against a company or a doctor, it's a bit of a feeding frenzy and a free-for-all. Well, if it weren't for specific colleagues, I would not believe you could treat everything with clear aligners that you can with fixed appliances, because I'm not a clear aligner guy. I mean, I never did those. I decided that wasn't something I was interested in. But if I was getting out of school now, Howard, I guarantee you I'd be all over that. You can't afford to not know about this because of the very effective marketing, a bit aggressive BioLine technologies. I mean, do you realize, Howard, that they have no proof for what their claims are? They claim that they have millions and millions of cases, and I don't doubt it. But why don't they publish evidence through a university, not their own evidence, because that's biased. That's selection bias. It's not going to work. But why don't they open the vaults and let the university people come in, postgraduate students, for example? And I have an opinion, Howard, about why they're not doing it. Want to know what that opinion is, Howard?
Absolutely. I had the Joe Hogan on the show.
They don't have to. Look at what their stock has done. They're printing money along with printing clear aligners. They don't have to do one thing to prove what they're saying. They don't see any need to. And today's dentists, including the orthodontists, don't require proof. Now, I came out of Northwestern University in 1981 under Harold T. Perry Jr. And knowing the literature, knowing anatomy, and knowing that evidence, and knowing orthodontic history was absolutely essential. Absolutely essential. Bending wires. The mark of the true orthodontist is you could bend that wire, you could make that thing boogaloo down Broadway. You could do it to it. Now, you don't need to do that. You have the pre-adjusted appliance. So the wire bending is a very, very minimal part of it. But also, today's dentists do not require proof. That's a terrible thing to make a blanket statement, but I'll say the majority of people that I run up against, they don't really require proof. They just, they say, well, it works, and they want some guru to follow.
So what exact evidence would you like Joe Hogan to to publish, or what evidence do you think needs to be examined from Alliance? And I'll tell you the answer why it is. I mean, I've had the chief economist of the ADA on this show, and I've had Delta CEOs of Massachusetts and other ones, and back to the amalgam composite debate. I mean, Delta's sitting on probably billions of claims. And I asked Marco Vukacek, well, you're both in Chicago. Why don't you call them up and go down there and start sorting their data with some algorithms, and we would learn so much. And he's like, there's no relationship there. I mean, I don't even have a contact over there. I'm like, well, how could Delta Dental and the American Dental Association on the same city as Chicago? I mean, it's because they don't trust each other, and it's because of the dentists. And I saw it when I grew up. My dad had 9 Sonic drive-ins, and the whole value chain, the guy who sold the meat, the bread, everybody worked together, went on vacations together. Everybody worked together to help deliver hamburgers faster, easier, cheaper to their customers. And then in dentistry, it's like, Delta will give some dentist a couple $100,000 a year in insurance claims. And the Delta will get like one letter from this dentist because they didn't cover like something, and he'll say, I can't believe you didn't cover this or raise my fees or this. I mean, the dentists just think they're God, and they think the crown should be, $1,500, and Delta should pay without any checks and balance. Again, it's just transparency and checks and balance. Dentists don't want any checks and balance, and I've sat at the bar with many of Delta CEOs, and I've lectured to their group, and they just try to avoid the dentist. I mean, it's kind of like the lamb and the lion. They're not going to be best friends. One wants to eat the other person, and so I don't think dentists have earned the respect. And I'll give you another example. I was at CDA one year, and here's Delta of California did over like $1 billion of sales, but the California Dental Association, they didn't sell $1 worth of insurance. And they had this lecture by a very famous dentist, Bill Dickerson, LVI, Cosmetic Dentistry, and said, Delta or the devil. And the Delta guy told me, can you believe this shit? We give these damn dentists, we went out there to businesses, sold $1 billion worth of insurance. We're sending these guys hundreds of thousands of dollars each, and we're the devil. And none of them have ever spoken at a major meeting. And the dentists are like, well, why can't we be friends? I don't know, maybe because you've treated them like shit since 1945. So I'll listen to your opinion. What would you like if Joe Hogan said, hey, man, you're a researcher, Cochrane, you're a research group. Would you want to look at my data? What exactly are you looking for?
All right. Well, one of their big claims is one of the more recent ones is they have these class 2 correction things with clear aligners, Invisalign specifically, and for mandibular propulsion, that they're going to correct a class 2 with these attachments or ramps to posture the mandible forward. That's been tried in fixed appliances forever, and it doesn't. And they're intimating that it's true skeletal mandibular growth. Well, nobody's been ever been able to do that in history. It didn't work with the Herbst appliance. It didn't work with the Frankel appliance. It doesn't work with the bionator, the activator, the univator, the urinator. It doesn't work. You cannot grow the mandible, at least with anything we've ever tried. but the latest now, Invisalign says they can do it. Well, how about some proof for that? Here's another one. They're making all of these claims about Invisalign first for mixed dentition. Well, all they're showing are case studies. Case studies are not scientific evidence. They are case studies. So what's a statistically significant sample about? Well, a statistically significant sample would be, for the people listening, all right, is that something that you're familiar with? Could you quote what the statistics are in order to say, yes, that is a statistically significant sample? What's the magic number? I'll give you a second to think about it. The magic number is 30. 30 randomly selected subjects or objects. It has to be at random. You can't just pick those that worked, and you can't just pick those that didn't. I digress momentarily into one of my favorite things is bicuspid extraction causes airway problems. Bicuspid extraction causes airway problems if you come from constricting the arch. All the evidence is that is an absolutely false statement. Absolutely false. And when I've been on programs with people who make the claims, I show them an abstract. I hand them the piece of paper that said, will you read that for me? And it says there is no correlation. Well, I don't believe it. Okay, belief system. In other words, you want to ignore the facts. So I go back. Invisalign first, mixed dentition orthodontics with Invisalign. They're making all these claims. All right, they're showing some case studies in the Journal of Clinical Orthodontics. But why aren't they showing any decent evidence, like 30 ran and published out of a university, not stuff they picked? Here's another one for Invisalign. The other one is treatment time. They're saying that the treatment times are shorter. Okay, well, how about some proof of that? I don't see any proof of that. It's the same with self-ligating appliances. You've heard about this, Howard. Self-ligating appliances, the claim was from the, well, I don't know, you say this is raw and uncensored. Am I not supposed to say the names of companies?
You're supposed to always say the names of companies. It's like when people say they can't stand me, I say, well, just make sure you get my name right and spell it right so they can find me.
Yeah, okay, good. So I would never do such a thing, Ormco, Damon, making these claims that it grows bone and that you don't have to take out teeth and that the treatment times are shorter. They were making those claims from the beginning, and they got their faces and their nose rubbed in it because all the evidence shows the treatment times are no shorter. As a matter of fact, there's one study out of, I believe the data came from St. Louis University from their orthodontic department showing that teeth move faster in a very interesting experiment. Teeth move faster. The slowest tooth movement was with the Damon appliance. Now, I don't know if that ever got published, but I actually have a copy of the master's thesis done by the student. And I can explain why that is, that it's slower movement, not faster movement. So there are some key things that I think Align, if they were interested in publishing, ought to publish. But again, nobody's demanding it. Nobody is making any of their financial decisions based on it. And do I mind if Invisalign doesn't? Here's a question. Do you think it bothers me that Align doesn't have any proof, any good evidence, like published in a refereed journal, not the Journal of Clear Aligners, not the Journal of Align Technologies, not Ormco's journal, not 3M's journal, the European Journal of Orthodontics, the Anglo Orthodontist, the American Journal of Orthodontics, a respected refereed journal. Do you think it bothers me that these things don't happen?
Yes.
It doesn't bother me at all. It doesn't bother me.
Why?
At one time it would have. But the only reason that I pay a hardline attention to evidence is I'm trying to do the best I can. And that means as much as I possibly can following clinical decisions based on science, because then when things haven't worked out in anybody in dentistry who says, oh, I've never had that happen, that's never happened, they're either lying or they haven't been in practice very long. Am I right, Howard?
Yes.
They're lying or they've not been in practice. And as soon as I hear that, well, I've never had that problem. Well, I'm thinking, okay, you just lost all your credibility. How do you solve that? How do you sleep at night? I told you, for me, I'm doing the best I can to pay attention to the evidence. I mean, how do you follow the fact that, okay, look, you did the same procedure in dentistry, and for the doctor, it appears that I've done the same thing on a very, very similar need, whether it's restorative or orthodontics. I've done the same procedure with the same materials in a very similar situation, and sometimes it works and sometimes it doesn't. How do you explain that? Well, the way you explain it is, if you look at data, there's something called a standard deviation. And if the standard deviation is huge, that means it's not very reliable that it's going to work on your case. If the standard deviation is small, there's a better chance it's going to work out, but it's not 100%. Never. It's never 100%. Now, once I realized in clinical practice, and I told you how I practice, I couldn't blame the assistant for doing something wrong, Howard. No, I did it. I put all the braces on. Took all the braces off. I placed all the archwares with essentially never one exception. I wanted to take the wires out so I could feel the friction and see how much was left in the wire. I tied the wires in myself. My assistant, I had the same assistant for 25 years. My assistant, I won't say never, but I will say, I probably had her put an elastic on a few times. And I know most people listening to this are going to say, unless they know me personally, they're going to say, I don't believe that. Well, that's how it was. So there was no assistant to blame. In those years of private practice, I thought, I have done the best I can on every patient. That's not the same result for every patient, but I thought I've done the best I can. So people making these claims, I think they're making it for ego and money, ego and marketing. It's like, if you like me, you'll be like me. And those people, I think, are boring.
Gosh, you said so many things I want to go back to. So, I mean, I want to go back to orthodontics even before that, before I can even get to where you're talking about, is, again, I've been very confused in my 30 years of being a dentist, that it wasn't the orthodontist pointing out that, that these orthodontic issues don't exist in old fossils. I mean, you just got to go back 1,000 years to all the way to Lucy, who's 1.7 million years old and right up the street from me at Arizona State University. They're saying that these malocclusions and all this stuff didn't exist in Neanderthals and Homo habilis and Homo erectus and all this old stuff. And then the orthodontists tell patients that orthodontics is to be healthier, a healthier smile and all this health stuff. But I mean, I have many edentulous patients who never wear their dentures and they're clinically obese. And I watched one, he was eating almonds and he was about 6'4". So I actually stood on a stool. I said, come on. I said, dude, do you care? I want to see you eat almonds without any teeth. And he's laughing. And I'm up there with holding his lips up, and he's throwing almonds in there, and these calloused edentulous ridges are just smashing the crap out of these almonds. And big man. So I want to ask you, is there any clinical evidence that having orthodontic treatment and having white, beautiful teeth, you're going to be healthier in any measurable fashion? Because to me, I agree that Invisalign has done a great job of marketing, because I've lectured in 50 countries. My boys were blown away. I mean, we could be sitting at a bar in, Cambodia, Malaysia, Indonesia, and the minute the waitress finds out that I'm a dentist, first question out of her mouth is Invisalign. And I believe it's all about being pretty as a peacock to attract a mate, so you can mix gametes, and that's what the only job a species has, is to mix gametes and replace yourself before you die. And I think the Asian girls explained this the most, because they were telling me they'd hold their finger from their nose to their chin. And if their lip touched their finger, they wanted their two upper bicuspids out to pull it back because they got tiny noses and they want that separation. Well, that's nothing about form and function and health and living longer. That's just all in your mind. That's what's going to give you the confidence to be as pretty as a peacock. And so I've always thought orthodontics was cosmetic, but you say to an orthodontist that, well, that's just cosmetics only. That's like a tummy tuck or a facelift, or they're like, no, it's health related. Okay, so what claims? So I'm asking you, the man, do all these children get braces so that they live longer, healthier lives, or just so they can be pretty as a peacock and can attract a mate?
Well, as a dentist, let me ask you this question. Any dentist listening to the program, have you ever seen a patient with a remarkable, not of this world malocclusion? You just think, wow, this is what happens when brothers and sisters mate. This is unbelievable. I've never, a class 3 open bite with the unilateral component, mobbed up crowding, asymmetry, blah, 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 blah. You've seen something. Do they necessarily have temporomandibular dysfunction? No, they do not. Are they more likely to have temporomandibular dysfunction? Yes, they are. So every study done, for example, here's another one. This was quoted by Vince Kokish. It's from the Journal of Prosthetic Dentistry. The study was that this was at a major TMD clinic in the United States. And anybody who would like an abstract, it was published in the Angle Orthodontist. So you can find it online for free. So here's the study. They take a statistically significant number of patients that have temporomandibular dysfunction, and they compare them to 80 asymptomatic adults. So asymptomatic adults says, my jaw has never clicked, popped, locked, or bothered me in any way that I can remember. And they're adults. Who are these 80 asymptomatic patients? The ultimate experimental animal. Dental students said, okay, I've never had that problem. What was the most common occlusal pattern in patients who were asymptomatic? Group function with a high incidence of a balancing contact in mandibular excursion. Did you catch that, Howard? It's the exact opposite of what I was taught and what most dentists are taught. That group function is actually more common in people who are asymptomatic, including a balancing contact, not a balancing interference, a balancing contact. Now, I can explain physiologically from my department chairman, Hal Perry at Northwestern, was one of the leading TMD people in the world. So your question is does having a healthier occlusion, a more ideal occlusion, does having an ideal occlusion mean you are healthier? That's your question. The answer really is the ability to adapt. So if a patient is past puberty, because Daniel Pisani's research in OOO showed that when passing through puberty, you are 4 times more likely to have a TMD or temporomandibular dysfunction incident, clicking, pain, locking, something. Once you're through puberty, that data drops. So if you see an adult and the adult is not having any TMD problem and has a malocclusion, they have adapted. That's Hal Perry stuff. They have adapted to their malocclusion. Their stomatognathic system is adapted. So here's one for you, Howard. What if they have a posterior crossbite? A posterior crossbite, no TMD, and crowding. They've adapted, right? Okay. How do you know that if you put braces on them, they'll adapt to the new occlusion you're going to give them? They may not adapt to it and become symptomatic. Ha ha! That's pure Hal Perry stuff. So, is it true that people that have better body posture have fewer back and neck problems? Yes. Is it true that people who drive their automobile carefully have fewer car wrecks? Yes. But it doesn't mean that person won't have a car wreck. It doesn't mean that person will never have a back or a neck problem. Is it true that people who have a healthier lifestyle become ill less often? Yes, but it doesn't mean they never become ill. So is it true that people have that for the person who has a more ideal occlusion, they are less likely to have temporomandibular dysfunction? Yes, but it doesn't mean it'll never happen. So when you say healthier, Howard, what's your definition of oral health? Because that's what it hinges on, is the World Dental Federation has a new definition of oral health. And if you like, when we're done, I'll send it to you. It's rather complicated, and Dorland has a much more abbreviated definition, which was quoted by Kevin O'Brien in one of his blogs. The ability to chew, the ability to speak, the ability to smile, convey a range of emotions, the ability to breathe is in there, lifestyle, quality of life, the ability to have a good quality of life, including good quality. That means, in their definition, to maintain their desired role in society. So if a person says, I really don't care that my teeth are crooked, I really don't care that I'm missing a couple buys, I really don't care that my kid is, or my spouse, or my significant other, I don't care. That person doesn't need, as long as they're pain free, they don't need anything. The only person who really needs orthodontic treatment, this comes from Rolf Gordon Barentz, the current editor of the American Journal of Orthodontics, and Lyle E. Johnston, who is Barentz's teacher. The only people who really need orthodontics are people who want orthodontics. So what I tell people is the best thing about what's done in orthodontics is it's all elective. You do, and I'm not talking about accidents, I'm not talking about syndromes. The best thing about orthodontics is it is elective. But in that definition of oral health, the maintaining your desired role in society. Well, we live in a culture here in the USA, and I've lectured in China 6 times. I've lectured in Vietnam about the same. I've done a lot around the world, and different cultures look at things differently. For example, in Japan, it used to be that if you showed gold when you smiled, you showed a line of gold, that was very, very high culture. That was very desirable. Not anymore. So if the person, take the USA, we live in a culture where you are very quickly judged by how often you smile, how you look when you smile, and how long you smile. That's from the psychological aspects of facial form from the Ann Arbor Growth Symposium. We very quickly judge other people in our culture based on those things, on their smile. Now, if you don't believe that, somebody not listen to this, really, you don't believe it? Well, now everybody has their lower facial third covered with a mask, and you have no idea what they look like. All right, so people say, when you survey people, Howard, again, this is from the psychological aspects of facial form from the Ann Arbor Growth Symposium. When you ask lay people, what's the most influential part of the human face? Not dentists, lay people. What's the most influential part of the human face? Most people answer the eyes, window to the soul. But then when you cover up or change different sections of the face, the most influential part of the human face is, Howard, look, Howard, look, with the hold your fingers up like this, Howard, with the fingers. Now you have to make a sound. Ready? Go ahead. It's where you go to work every day, Howard. It's right there, because you're going to work right now with your lower facial third. You're speaking. The most influential part of the human face is the lower facial third. And now everybody believes it because people are wearing masks and you have no idea what they look like, you see? So what we do in dentistry, not just orthodontics, but what we do is really important. And if a well-balanced smile is important to someone, bring them on. And if they don't care, don't bring them on. So obviously, this is something I enjoy speaking about, because orthodontists who act like if you don't have braces, or if your kid doesn't have braces, they're going to be a wart on the face of society. They're going to be some sort of deviant. They're going to have TMJ problems. They're going to have periodontal problems. There is no proof for that. Or they're going to have airway problems. There is no proof for that. Here's another one. How about this? Let me ask you this question, Howard. Are you under the impression that malocclusion, including crooked teeth, that has something to do with speech patterns? Do you think
not, no?
So you think not?
Well, I mean, I don't know. I'm not.
No, come on, Howard. You're a brave man. Do you think, as a dentist, that malocclusion has anything predictable to do with someone's ability to speak clearly?
I don't think so.
Well,
I mean, look at the lead singer of Queen. I mean, that guy had a horrible overbite. I mean, you listen to Queen, you watch him, you had to listen to him. You couldn't watch him because you're thinking, how is that overbite making those beautiful sounds?
Oh, that guy had overjet. He could eat a sandwich through a picket fence, that guy.
Yeah.
And you could hear an altered speech sound in his voice. I mean, when I watch the movie and listen to the music, but I'm listening for it. So check this out, Howard. When I was a postgraduate student at Northwestern, we were adjacent to the speech pathology department. And as I recall, the head of speech pathology was a very, very bright woman named Judith Trost, T-R-O-S-T. Now, I don't think this ever got published, but one of her PhD candidates did a study about malocclusion in speech. We, as postgraduate students, sat in a room, and patients in a different room, we listened to them speak over a telephone through a speakerphone, and they read the same paragraph. And we had to check boxes as postgraduates in orthodontics. We had no idea what the patient looked like. They're in a different room. Class 1, class 2, class 3, open bite, cross bite, asymmetry, crowding. We had to check boxes. Do you think there was any chance that we could do it? Zero. None. Conclusion, that if a parent or an adult patient is under the impression that having orthodontics will change their speech pattern, they need to understand that that is absolutely not predictable. If that's their it's one of my big things, Howard, is patients and doctors must have realistic expectations. You're talking about a restoration. Well, how long should the restoration last? Well, if the patient's not informed, they may think the restoration should last from now until death do us part. Nothing lasts that long. I mean, I have amalgams in my mouth that have been there since I was 14. And I don't think that it's done. I think that's why I have a head of hair. I think it's the amalgams. How about this? Here's another one for you, Howard. Here's another one for you. X-rays causing cancer. Is that true? Is there any evidence whether it's true or false? Now, this should be important to every dentist listening to this, every layperson listening to this. There was a doctoral dissertation by Rolf Gordon Behrens. As I mentioned, he's the current editor of the American Journal of Orthodontics, called Growth in the Aging Craniofacial Skeleton. It was his PhD dissertation. He looked at over 100, I believe it was 163 patients from the original Bolton sample. Now, I'm going to take a little bit of your time to explain what this is. The Bolton sample was at Case Western Reserve University. It was started during the Depression. It was funded by, privately funded for reasons I won't go into, but there was no problem with funds, and the study was of well children. So from the time little kids were brought in, including, check this out, Howard, pregnant women, and they were being x-rayed with high dose x-rays in the 30s, in the 1930s in Cleveland, Case Western, the Bolton sample. No one knew there was anything dangerous about x-rays. No one knew at the time they were dangerous. So on or close to their birthday, and as I said, including they were x-raying pregnant women, on or close to they were x-raying the fetus, on or close to their birthday, starting at a very young age, I believe it was 5 or 6, every year you would go in to have the x-rays done. Lateral ceph, frontal ceph, hand, wrist, photographs, and so on and so on. The study stops at the mean chronologic age of about 25 years. So this goes on for a long period of time and then stops. Boom. Behrens comes back 40 years later to find out what happened to these people and get them in. If they're alive, he gets them into the clinic if they'll come in. Back in the Case Western. But now they're going to be x-rayed if they agree to it on modern machinery. This particular part of the study I'm talking about, think about what was the incidence of death from cancer or other degenerative diseases, because these people were getting hit with high dose cumulative x-rays, including in childhood. Was the incidence of death 40 years later, mean age of 65, was the incidence of death the same as the general population of Cleveland? Because these are middle income people. It's kind of average walking around Cleveland people, not high income, not low income, in the middle. Was the incidence of death the same, less, or greater than the general population? Because what would you think from getting all these x-rays?
That they had higher.
It was lower. It was lower. Growth in the aging craniofacial skeleton, 1985, Rolf Gordon Behrens. It'll blow you. It's the exact opposite of what you think. Now, no one is saying that x-rays cure cancer. That is not the conclusion. The conclusion is even these high dose x-rays with no collimation, no high-speed film, x-rays are these types of x-rays, talking about a lateral ceph and a frontal ceph, are nowhere near as dangerous as people think or claim. So what to do when a patient says, no, I don't want you to do x-rays. You cannot do x-rays. And I'm a new patient. What would your answer be, Howard? You're a general dental specialist. What would your answer be if I said to you, nope, you can't do any x-rays on me? What would you say to me?
I can't treat you. There's 1 million attorneys. There's 1 million MDs. There's 1 million attorneys. And in our society, I have to CYA.
My answer sounds just like this. First of all, I say to them, I am very concerned about x-rays. I'm around them all day long. May I ask what your concerns are? Now, the patient or parent who says to me, well, actually, yes, you can ask. My brother or my brother-in-law or such died of a glioblastoma, or thyroid cancer was, someone was a victim of thyroid cancer. That is a completely different situation or patient. Someone says, no, Gerry, no x-rays. No, they're just like the vibes. The vibes are bad, man. They're just bad. No, that's a screwball. Now, what I do then is I did an abstract of Behrens' stuff, and I show this to them. And I tell them, you need to think about this. But I also need to point out to you that what you are asking me to do is diagnose, treatment plan, and treat you or your child without the appropriate information, without the appropriate diagnostic information. You're asking me to do that. Now, there's a name for that in our culture. It's treatment below the standard of care. It's also called malpractice. And I can't do that. So please get some other opinions. I'm sure you will find somebody who will agree with you. You know, this is the same craziness. And I mean that. I mean, I'm fine for them to leave, but I'm not going to be rude to them, because a lawsuit is not the main thing we need to worry about these days, is it, Howard? That's not the main thing to worry about. What is the main thing to worry about? The internet. They're going to go home and body slam you. and they're going to whip up on you, and they know they can do it, and it's freedom of speech. They're going to get away with it, and you can't do anything about it. By the way, have you had Len Tao on this program?
Len Tao? No.
Bird Eye? T-A-U. Howard, you got to get him on here.
How do you spell it?
T-A-U. Leonard Tao. T as in Thomas, A-U. That guy knows more about social media.
Oh, yeah, Leonard Tao. Absolutely. I've had him on the show.
Yeah, reputation of media management. Brilliant guy. There's another guy named Evan Lazarus. Evan Lazarus. He's a search engine optimization expert. You really should get him on the show. He's not a dentist. Evan Lazarus. Brilliant, brilliant guy.
Well, when you say Lazarus, I mean, the first thing I'm thinking of for you is Gasper Lazarus and his son, John Lazar. I mean, DSOs are a major thing. And as far as free thinking, of course, the dentist or the center of the universe and the insurance companies and everybody else are supposed to stand in line. But I think that you should have one eye on the customer, the patient, and one eye on cost, and use your brain to make everything faster, easier, higher quality, lower cost, smaller to serve the customer. And out here in Phoenix, until we had DSOs, if you fell off your bicycle and broke off your front tooth on a Sunday, you would never find a dentist open. I mean, you'd find 3 mermaids riding a unicorn before a dental office open. Now, because of DSOs in Arizona, there's dental office open 7 to 7, 7 days a week. You're an orthodontist. I think the biggest DSO that started this whole thing was Gasper Lazara down there in the same state you're in Georgia. And he did the Orthodontic Centers of America, and he instituted that. He didn't know why you were financing this thing when orthodontists incur their cost each month. So the treatment would be $6,500, and the orthodontist would need like a third down. And Gasper is like, well, are you going to prepay a third of the next year's rent, mortgage, equipment, build out computer, insurance, malpractice? It's crazy. And he came out with this program that said, hey, just $199 down, 0 interest financing, all credit approved, $199 a month, and you can have braces. And the market loved it. And it was the only DSO to do a IPO on the New York Stock Exchange. And of course, we all learned that dentists are, it's like, managing dentists is like herding cats, and the whole thing fell apart and imploded. And then it was gone for a decade, and now DSOs are back. So when you say Lazara, or Lazarus said, my God, I've been trying to get Gasper to come on this show. He was the first guy I contacted to come on the show, and I've still never even got a return. Probably because he thinks, that I'm a dentist, so we're just all anti-DSO. But Gasper, what did you think of Orthodontic Centers of America and that whole?
Never bothered me.
Right?
No, I mean, that's why in the South we have a saying, Howard. That's why they make chocolate and vanilla. If somebody wants. Who you really should try to get on the show instead of, since Gasper doesn't want to do it, is Pete Pickron, Pickron. Pete Pickron. He would be a great person to have on the show. Pete Pickron, Pickron. He's an board certified orthodontist. He also had he owned 23 clinics here in Georgia, well over 100 employees. He would be a very interesting person to have on the show in that model. So that model is, you just explained it. Matter of fact, the Pickron model was no down payment. You don't make a down payment. You have, what do you have? You got $30, you got $50, sit down, we'll put your braces on. And then you paid per month. And from a business model, Pete figured out that you could do very, very well. So you're treating a specific segment of the population. So it's high volume with the assistants doing the majority of the work, being supervised by an orthodontist, but we're talking about knocking out 100, 150 patients a day. That is a specific model. I mean, think of it as kind of a fast food thing, like McBraces, all right? That's one end of the spectrum. If that's what the patient wants, and they are informed that the doctor is a supervisor, that the assistant does the work, the doctor checks and supervises, or at least they're supposed to. All right, let's say they are. As long as they're informed, great. But where there's a problem is when the parent or the adult patient doesn't understand that the doctor is going to have minimal contact with the patient. That's a problem. The patient has the right to be informed, ask questions, and give their consent. It's not just in consent, it's informed consent. Now, my practice was I did all my own treatment. So was there, Howard, do you think there was a difference in treatment cost in my practice versus a high volume? Significant difference.
Yeah.
Significant. As in not a little more, a lot more money. And I would explain to people, I would ask them, is this your first experience with an orthodontist? Now remember, it's kids and teenagers. So if they had been seeing someone else with an older kid or whatever, all right, then they have some experience. But let's say their experience is zero. My explanation to them was, it's very important to me that you understand how my practice runs. There are different ways orthodontics is practiced. In some orthodontic offices, the orthodontist is a supervisor and has a number of assistants, anywhere from 3 to 5 to even more in multiple locations. The assistant does the work the doctor supervises. There is nothing wrong with that, nothing. It is not illegal. However, I chose long ago to not do that. And when your son or your daughter comes to my office, when they need to have something done, I'm going to do it right then. Because if you, Howard, were my brother and that kid sitting next to you was my nephew, it's my nephew, needs to get it done now. But it's only fair that you should understand you pay a price for my type of service. And I've been told I'm more expensive than most people. And in general, it's true. On a given patient, it may or may not be true. So for example, Howard, I charged significantly more for a difficult case and significantly less for an easy case. I didn't charge the same thing to everybody. And remember, I said I didn't accept insurance payments. The front desk would show them how to fill out the insurance, but they had to pay me directly and the insurance company would pay them back directly. So I don't have any issues with the models where like Gasper Lazera, or I don't have any issues with that at all. Just like, how about this one? Smile Direct Club. There's one for you. Do it yourself at home orthodontics. The orthodontists are nuts. Give us Barabbas. This is killing the specialty. I think, well, anybody, Howard, that would want to do it themselves at home would never come to my office. That's not competition. Just like denturism. Remember that whole rip, Howard?
Yep.
Where they were going nuts that we can't have denturists. I think, okay, why not? If that's what someone wants, let them go have it. This is the USA, man, the land of choice. So that's my answer about DSOs. And not all DSOs are the same. The one that I'm involved with, specialty dental brands, there is a misconception, Howard. The misconception is when you hit a certain volume, a certain business volume, there is a bend point, like in statistics, where the customer service and the quality of care are going to suffer. The customer service and the quality of care are going to suffer at a certain volume. You know what I say to that, Howard? Tell Disney that. Tell Walt Disney that. Tell Neiman Marcus that. Tell Nordstrom's that. That is not necessarily true. It depends on the leadership and the direction of that company that is set by the leadership and the managers of that company as far as the quality and customer service. So for the company that I'm with, Specialty Dental Brands, led by Michael Schwartz, CEO, not a dentist, business guy, that is our commitment. That's our reputation. Our company has doubled in size in the last 9 months because all we're looking for are people that are functioning at that end of the food chain. So yes, I'd get Pete Pickering on the phone.
Well, gosh, so many things. When you were talking about the clear aligners are Invisalign wanting to show their data. And you're talking about all this Cochrane research. One of the biggest problems I have with all the research is that most of it's funded by the individual tax-paying dollar, the working man. He's working at the IHOP, and the taxes go to these universities. They do all these research, and then when they want to get published, they go to put it in a journal, and now that research that all the people paid for is behind a paywall, and you can only get a summary, and if you even give them money, you just get to read the actual study. You don't have the data source. It's not in an Excel spreadsheet. I think I think the way free enterprise has gone in, I mean, I own a media company. I know exactly how they work. And why do these publications get a monopolistic ownership of all the research, and why isn't the internet just a sink where all the research just funnels all down into one thing, and you just build a tree of knowledge instead of behind all these firewalls and everything?
Yeah, paywalls. Well, we're on the same page on that one, Howard. I think it's wrong. If it was funded with taxpayer dollars, that should be public access. What they allow, except for the Anglo Orthodonts, that is online from its inception, all for free, and all they do is ask for a donation. And you can do it if the spirit moves you to donate money to them, but you don't have to. But the rest of the journals, I couldn't agree more. I think it's wrong. Now they make abstracts available, but I think it's wrong.
But you need the actual data. I mean, I don't want to see your you did something in your opinion and what you found. I'd like to see all your raw data. And with the use of computers and algorithms, and you'll just keep getting a bigger and bigger and bigger pool of data, and God only knows what the algorithms will find and how to sort out all that data.
Well, for people listening in, Kevin O'Brien's orthodontic blog out of Manchester, England, it's free. He's not soliciting anything. He's not going to gray you out. He's not going to give your email away. It is brilliant. Kevin O'Brien's orthodontic blog. It is about as unbiased as anything you'll ever read. And I can't say enough good things about it. And the way it's organized too is the same questions you would ask. For example, they'll say on a given article, what did they ask? How was the data well gathered? Was there selection biased? Was it a statistically significant sample? What were the weak points? And then at the end, O'Brien says, well, what did I think? And how will it change my practice? So that's a tremendous resource, but I couldn't agree more that stuff should not be behind a paywall. But
well, that's the norm, though. I mean, that's just how.
It's not right.
That's the norm.
Here's one for it. And I know we're probably getting to the end of our effervescent.
Yeah, but man, I'm not getting rid of you. If you're still talking, I'm still listening.
Here's one that I thought you're going to bring up: the American Association of Orthodontists. Not teaching classes for non-orthodontists.
Well, I mean, I'm in the city with one of only two, Harry Green, who's an orthodontist who teaches general dentists, and the other one is Richard Litt. And they will both tell you that when you're an orthodontist in the United States of America and you start teaching general dentists, you are just, you're just blackballed and marginalized in your profession. I mean, the AAO, but everything's a trade-off. I don't really believe so much in right and wrong. It's like up, down, left, right. What are the trade-offs? The American Orthodontic Association, they kind of remind me of a bunch of animals just forming a circle, and you're either in or out. And they have the highest membership of all the specialties. I mean, the ADA is about 65%. That's about the norm. The AAO's got about 95%. So if they've taught me anything, it's that if you just fanatically extremism support your members, you'll get them all. And they do.
Well, the American Academy of Pediatric Dentistry has a super high subscription rate for membership. I think the AAO membership has been dropping precipitously over the years, because the new generations, not the most current, but the last few generations of orthodontists don't really perceive that the AAO is doing enough for them with their massive debt and difficulties such as that. I mean, the the AAO has every right to say that if you're not an AAO member, if you're not an orthodontist that went to a recognized school, a codified school, as I call them, codified, you can't be a member. Well, I don't agree with that. Now, you already mentioned I'm boarded in orthodontics, but I'm not boarded in pediatric dentistry because I never practiced full-time pediatric dentistry. I went right into ortho. So, I can't be a full regular not certified. That's not fair. I can't be a voting full member of the American Academy of Pediatric Dentistry. I can only be an associate member because I never practiced pediatric dentistry full time. Do I think that's wrong? I don't care. Doesn't matter to me. Do I think that the AAO, the American Association of Orthodontists, do I think that they're doing the wrong thing by not encouraging non-orthodontists to be members? I think they're wrong. And you can go to an AAO meeting. You can register and go to the meeting as a non-member, but they kind of have that slipped in between the pages. You can. I think that trying to keep things secret, it's just like telling a kid, you know what, you can't watch that movie. You know what, you can't listen to that music. You know what, you can't go over to that kid's house. You can't be friends with that kid. What's the first thing the kid wants to do? Go do it.
I can still remember sitting in Mass at St. Francis of Assisi, and Father McGloin read a letter from the Bishop of Kansas that there was this new rock and roll band called the Police singing a song about Roxanne and prostitution, and it's been officially banned from the Catholic Church, and make sure none of your children, and I'm sitting there like, I never even heard of this band, and only one radio station was playing it, and it's T95 out on Maze Road on the edge of town, and these are despicable people. After Mass, I drove and found T95, went in there, got the little sticker on my window, then drove to a place and paid like $11 for this cassette called The Police, and listened to Roxanne, and oh my God, it was just, thank you, Father McGloin. I mean, he turned me on to one of the greatest rock and roll bands ever just by banning it. My God, I could talk to you for 40 days and 40 nights. I want to ask you, since you're an orthodontist and a pediatric dentist, I have noticed, look at Clear Choice. Retail says put everything in under one roof. The first time I lectured in Australia is like 1990, and I'm going out for groceries with this dentist, staying with him, and we had to go to here for the bread and here for the meat, and we had to go over here for vegetables. We had to go to like 5 places that I would have just gone to Dillon's or Safeway, all been under one roof. And Clear Choice put the implant surgeon, the prosthodontist restorer, the lab tech under one roof, and Clear Choice, it's just exploded. It's been bought and sold 5 times. And I've noticed that when, if you took 100 kids to a pediatric dentist, 100 parents are going to say, hey, will little Billy need braces someday? And it's not under one roof. They write a referral. You got to go down the street. Now, when you see a pediatric dentist and an orthodontist open up together at the same time, it's 1 + 1 = 3. I'm here in Phoenix. You look at, here's a new pediatric dentist. Here's a new orthodontist. Here's both under one roof. The both under one roof is exploding, and it makes sense. Mom's busy. She doesn't have time to go to all these people. So what do you think about pediatric dentists and orthodontists just getting married? I mean, always under one roof.
I think it's, as you say, it would defy logic as to why you wouldn't be doing that. Now, it has to make business sense. And there is here's the biggest liability. If first of all, the patients are coming from the pediatric dentist. That's almost a one-way street, that the referral line is going to be from the pediatric dentist to the orthodontist. And if the orthodontist cops an attitude that they don't want the pediatric dentist doing any orthodontics, that is the first sign of a big problem, because the orthodontist is a prima donna and very close-minded. By the way, my education company that I've had for 35 years called Nathos, I am not dogmatic enough. I mean, it's hypocrisy to say I teach, but I won't teach you. I won't teach you because I don't like guys that don't have as much hair as I do. I won't teach you because I don't like guys that are taller and better looking than me. I won't teach you because I don't like people that are short and wide. I won't teach you because you're from here or from there or no, I think it's complete hypocrisy. Anybody who is interested enough, because Nathos, my education company, that's for people that are looking for a more sophisticated approach. It is for people that find out that orthodontics is not always easy at all. That's what you find out. Same thing with clear aligners. Clear aligners, people find out that the lab tech on the algorithm, that doesn't always work. And what are you going to do when it doesn't? Now, your question is I think the most appropriate thing about the question is, or the answer or the thought process is, if a pediatric dentist brings an orthodontist in, there's an issue. And the issue is, if it doesn't work out and the orthodontist leaves, who's going to treat those patients? That's a problem. It's going to make the pediatric dentist look bad. The first thing, because you have a doctor-patient, doctor-parent relationship, and that becomes violated, makes the pediatric dentist look bad. There has to be, you have to have that consideration. And if the orthodontist brings in a pediatric dentist, it's basically the same question as, what if it doesn't work out and the pediatric dentist leaves? Well, another pediatric dentist can take over, but in orthodontics, lots of orthodontists, including me, I would not take transfer cases unless the orthodontist called and talked to me ahead of time. Because invariably there was a huge amount of misinformation. How long are the braces going to be on? What's being done right now? What about the money? Because people deserve to be paid for what they can do. How do those questions get answered? So it makes all the sense in the world to have general dentistry, pediatric dentistry, orthodontics, oral surgery, maybe having, a circuit running periodontist in there, maybe an endodontist. That makes complete sense to me, doesn't it, Howard? It's a business model. It's terrific. But the business model has to include, what are we going to do when someone wants to leave? How are we going to handle that?
Well, I love your site. In fact, I love you. I love your mind. I'm jealous of your hair. I think the best, your videos are amazing on YouTube. His YouTube channel, my gosh, it's youtube.com/Nathos, GNATHOS. He's got all kinds of videos, and man, I think the best marketing you do, I know my homies, when they do CE, they want credit for it. And we put 400 hour-long courses on Dental Town, and they've been viewed over 1 million times. You should put one of your intro videos. You've already got the content. You should put one on with Howard Goldstein. He's head of a online CE and Dental Town message boards, and put one up there for extra credit, and then they'll go there for the extra credit, and then it says, for more videos, click here and go to your list of videos on your YouTube channel. But I think I really do. I think you're one of the 1,000 points of light in dentistry. I love your Odd Couple podcast. Oh my God, you guys are just hilarious. You're funny. You're an entertainer. My gosh, I could really talk to you forever. Can I ask a couple more questions? Teledentistry, is that, the one thing, sometimes fads come, and then when the pandemic lifts, it's gone or whatever. Do you think teledentistry is a COVID pandemic technology that will fade away when the pandemic lifts, or do you think teledentistry was a game changer and it's here to stay, and there's just going to be a lot more of it?
It's just like telemedicine. Telemedicine is skyrocketing. There's a stock called Teladoc that has just exploded. Teledentistry is here to stay. And unless they've changed it, and maybe they have, but the American Dental Association is way behind the times on this. The last thing I read from them, and again, I'm happy to stand corrected, because corrected they must. The American Dental Association is saying that a virtual visit, the requirement is that it's essentially the same as an in-office visit. That's impossible. teledentistry, teleorthodontics, telepediatric dentistry. It's very, and again, Larry Gerald is somebody to talk to about this, the attorney, orthodontist. The decision you're really making is, do you need to see the patient? And if so, how quickly? That's the basis of what you need to figure out. So for example, new patient screening. Teledentistry is fantastic for that. And I have heard about, I haven't actually read the studies, but I've heard that there are studies showing that in medicine, the medical patient, physical medicine, prefers a virtual visit with the doctor looking at them and rather than being distracted. And so in teledentistry, it's a simple question. How quickly do you need to see the patient? Is there an emergency? As far as orthodontics, it is the future, because if you're an orthodontist listening to this or a clear aligner proponent, how often have you seen somebody and said, geez, this looks great, keep wearing your rubber bands. This looks great, change your aligners. Whoop, this aligner is not seating all the way. You need to back up one aligner. You need to back up two aligners and then restart, because the consistency, you can see that, you can decide that virtually. So I'm all for it. As long as people understand what it is, obviously you're not going to do a filling, but you can decide, is there pain? Is there swelling? How long has it lasted? That can be done virtually.
And I know this is silly, but what's the TE stand for after your name? The initials? I mean, your initials, DDS, ABO, FACD. What's a TE?
Tribal elder.
Seriously?
I wanted to see, I told Stefan Reinhardt, I want to see if Howard asks me what the TE is about. Yeah, it's like George Patton gave himself a General Star during the war. And I thought, as you mentioned, I have 6 university appointments around the country. Most of them are, in fact, orthodontic appointments. University of Alabama at Birmingham is pediatric dentistry, and Tennessee, University of Tennessee at Memphis, that's pediatric, but the rest are orthodontic appointments. And one of the postgrads said to me, well, Gerry, how do you see yourself now in orthodontics or in pediatric dentistry? You know what my answer was? I'm a tribal elder. I'm 72 years old, and I finished dental school at Marquette in 1975.
Wow, that is amazing. And gosh, so back to one last deal that I can't figure out. I've been trying to figure out for 32 years what is the standard of care, and one of the things that I think is the biggest issue in Orthodontic Centers of America or these DSOs or all that kind of stuff is you can't get 2 dentists to agree that today is Wednesday. My God, you can't even get them to agree what is the standard of care, the research, diagnosing and treatment planning. I mean, I understand how the assembly line worked to stamp out a bunch of cell phones or cars all identical, but dentists, they all see everything differently. How do you get a standard treatment plan that pediatric dentists, group practice, multi-locations can all agree on, and then get the lawyers to agree that it's standard of care? I mean, how are you going to wrestle that nest?
Well, I think from a diagnostic standpoint, I don't think there's a lot of disagreement about what the standard of care is to diagnose a dental orthodontic case, pediatric dental case. And do I think that there are standards in place that in order to make an accurate diagnosis, you must have this information, or the diagnosis will be below the standard of care. So I don't think there's a lot of disagreement on that. I think where the confusion is on treatment plans. That's where I see a lot. Do you know that there's a study out of the University of Florida orthodontic department? Cal Dolce is who published this in the AJO. Howard, you're going to love this. They gave faculty member orthodontists. Now, my memory is fading. I know it was Dolce, D-O-L-C-E, Cal Dolce that did this, but he gave cloned orthodontic records on a number of patients. It might have been 5 patients to a number of orthodontists, practicing orthodontists, and it might have been 8 or 12. And they're all the patients are class 2. So the question is what is the class 2 discrepancy caused by? What's the etiology? Is it the upper jaw, the lower jaw, the upper teeth, the lower teeth? There's 4 things. And then you can permutate those. Upper jaw, upper teeth, lower teeth. And they're cloned records. Okay? You got the picture, right, Howard?
Mm-hmm.
How much agreement do you think there was among the orthodontists?
No statistical difference.
That is correct. They could not, there was no agreement. There was no agreement. Upper jaw, upper teeth, lower. But here's the best. What they did then was they gave the same records back to these same orthodontists a month or 6 weeks, something like that later, and said, all right, tell me again. They didn't agree with what they said the first time. They didn't agree with themselves. You got to love this stuff. So this is why this goes back to what I said earlier, that once the doctor comes up with a treatment plan, a treatment sequence, a set of treatment options. So you have a set of treatment options and then you have a plan. We'll call that plan A. And plan B is what if plan A isn't working? Once that's presented to the patient is now needs to make a decision about if they're comfortable with that or if they would like to pursue other opinions. So as far as a lack of agreement on treatment plans or treatment options, as I call them, that is up to the patient to decide. And it is incumbent upon the doctor to offer those options and perceive and answer all the questions. What I tell people all the time is this: don't tell me you don't have time to answer their questions. You don't have time for what's going to happen if you don't answer their questions.
So one last thing on the speeding up treatment faster. What I think a lot of people are doing is instead of just seeing a patient once a month, which you could argue came from, well, the orthodontist pays his bills once a month, you pay your rent once a month, that we'll just see you once a month, and that some people are saying, well, I'll just see him twice a month, so instead of 2 years, it'll take 1 year. True or false?
I mean, there is the data on, I don't think that anybody, I think it's going to be a real stretch to ever have a comparison of treatment times based on appliances. I just can't see that happening.
Well, hey, last question, or I'm going to get shot by my producer. But this reminds me of going all the way back to when we were young. I remember back in 1997, God, now it's 2021, when Pulitzer Prize winning William Eckenberg at the Reader's Digest wrote how dentists rip us off. And he took a set of study models to 30 different dentists, and he got 30 different treatment plans. And then the NIH said, is this for real? So they said, we're going to redo the study, and we're going to do it with 100 people. They went to 100 people, and the only 2 treatment plans that were the same were the 2 guys who said the patient needs nothing. And then treatment plan 3 through 100 was all different. And that's why my favorite joke in dentistry is when someone's just going off the deep end crazy. I'll say, well, you know why dentists argue so much? It's because the stakes are so low.
Yeah, I like that.
And man, I gotta run. But I'll tell you what, big fan of your podcast. My God, The Odd Couple. That is so cool. And
Thank you.
Hey, you have a welcome invitation to come back to the show. Wish you'd put you got so much content. Put something up on the Dental Town online CE just to market your own self and name and brand to all the 250,000 dentists on Dental Town around the world, and keep doing what you're doing. And I think old guys like us, the only value of knowledge is if it's transferable. And if you take all of the knowledge to your grave, and because you're afraid you'll upset someone or you're afraid it's controversial. I love people who just say, if I really love and respect you, I'm going to tell you what I think. And all these people that think social media is so bad and they're trying to ban people off of social media and Facebook and all that kind of stuff. Well, my God, what do you want to go back to? We got 110 billion Homo sapiens have lived and died. We don't even have their name, let alone one thought. I wish they were all on social media and at least could know what they were thinking. I need a diagnosis and treatment plan. I need some records. And I think having people on social media say what they absolutely think, whether it's right or wrong, crazy, whatever, it's a starting place to what we're working with. And I just love it when tribal elders like you aren't afraid to piss off anyone and you just tell it like it is. And like I say, I don't care if anybody agrees or disagrees with me, but they should respect me that I respect them enough to tell them what I honestly think. And like I say, and if you're going to say something bad about me, just make sure you spell my name right and tell them it's called Dentistry Uncensored and you're the Odd Couple podcast. And anytime you want to get wild and crazy, come back on the show.
Howard, I can't recall when I've enjoyed myself more. Thanks for all the time. It was wonderful. Thank you.
All right. Have a great day, man.
You do the same. Bye-bye.